Welcome to CHCF's briefing on payment reform. My name is Catherine Rodriguez. I'm a program officer with the California Healthcare Foundation's State Program Office here in Sacramento. And it's great to see so many people here today and also joining us online and via phone line. CHCF is an independent foundation dedicated to improving healthcare delivery and outcomes. We are based in Oakland, and we support innovations and ideas that improve quality, increase efficiency, and lower the costs of care. Today's convening is one in a series of briefings that we hold here in Sacramento for agency and legislative staff, as well as other key stakeholders. The briefings are designed to bring you key information on healthcare issues and trends and to inform state policymakers' decisions. We also will have 2 more briefings coming up in October, and if you're on our list, you will hear of those coming out in the next few weeks. Today's event is being videotaped, and we will be posting it online on our website afterwards. In addition, as I mentioned, there is a webinar and a phone line open. They're on listen-only mode. And without further ado, I'd like to turn it over to Mary Beth Shannon. Mary Beth is the director of our foundation's Market and Policy Monitor program, which is working to promote greater transparency and accountability in California's healthcare system. Mary Beth?
So this is, as Katie mentioned, a briefing on payment reform. As enrollment picks up next Tuesday in terms of ACA, I think the focus is going to shift from people getting enrolled and having coverage to how much we pay for coverage, and particularly in this session, how we pay for coverage versus how much at the moment. So we have 2 sets of presentations. One's going to be a tag team by Suzanne Delbanco and Andréa Caballero, who are both with the Catalyst for Payment Reform. And they've been working on a national level with employers looking at payment reform issues, and they published a national scorecard on payment reform earlier this year, and today are going to release a California-specific report card. And then we also have Joy Grossman. Joy Grossman's a senior health researcher with the Center for Studying Health System Change in Washington, D.C. And the center conducted, on behalf of the California Healthcare Foundation, a series of reports in 6 regions in California. And we released those individual reports, but today Joy's going to talk about some cross-cutting themes about payment reform and what we're seeing in different areas of the state. But I'd like to set the stage by talking a little bit about how much healthcare costs have changed over time. And I'm speaking with slides that are drawn from a presentation that we released just a couple of weeks ago called Healthcare Costs 101. It's an annual publication that we do. You can find this on the CHCF website. But I'm going to take just a few selected slides to kind of set the stage. That's just the cover, so you recognize it on the website. So the first slide here shows over an extended period of time, from 1971 to 2011, how healthcare costs have changed. Those are the major gold bars. And you'll see the last 2 bars, which are 2001 and 2011. In that 10-year period, healthcare costs had slowed dramatically over the prior periods. And in the little box, kind of the brown bars that you can see in the small box, actually does a more in-depth look at the last few years and the effect of the recession. So many people who've been studying this phenomenon of why healthcare costs have decreased are focused on the fact that it was largely due to the recession. People lost their jobs and their associated health insurance coverage, and therefore may have deferred some of their health care needs. There's a possibility that some of that decline is also due to changes in the way we pay for health care. So we'll see as we investigate further this morning. But I wanted to go a little bit more in depth in this slide and show how the trends are changing and where we predict this to be going in the future. So the solid lines you'll see bring us up to 2011. And obviously, the blue line at the top is national spending, so those are US numbers. And then the gold line is the gross domestic product. So it sort of shows how the economy's going and how that's affecting healthcare costs. And they move somewhat together, but you'll see that when we had the huge economic drop in 2008, healthcare costs did not drop as dramatically at that time. But now as we've come the last couple of years, those 2 lines have converged a bit. So if you look at the dotted lines coming off of 2011 and where we expect things going, you can see a big blip in healthcare costs coming with the implementation of the ACA. And I'll get a little bit more into that. And the economy probably continuing on a steady state if still a little bit of a decline. So this goes a little bit more in depth in what the heck is happening in 2014. So you can see the big increase, the green line, which is Medicaid coverage. Obviously, that's the Medicaid expansion that comes in. There will be a huge increase in Medicaid costs anticipated in 2014. And the other dramatic change you'll see is the kind of gold dotted line at the bottom, which is out-of-pocket costs. And that, of course, makes sense. You have a lot of people who've been paying on their own for health care visits and even hospitalizations, and that's going to decline. As people get coverage, we're going to see a drop in out-of-pocket costs. I like this slide because it kind of brings home a really important message about how healthcare coverage and the distribution of who pays for it has changed over time. We actually have an interactive model of this that you can find on the CHCF website as well, where you can actually look at how these lines change over time. But this is a static version, and the most dramatic change I think you'll see is this big gold section in the middle, which is out-of-pocket costs. Out-of-pocket costs in 1961 represented a huge portion of how health care was paid. People paid for it on their own, or they had major medical kinds of plans with large deductibles and copays. And over time, as there's been an increase in government insurance, that has lessened so that now out-of-pocket costs represent only 11% of total health care costs. So there's been just a dramatic change in who pays for care. This slide just kind of summarizes how California and the U.S. are a little bit different. Up to this point, I've been showing you numbers that reflect the U.S. Healthcare costs and the U.S. economy. This actually shows California in the blue bars and the United States. So in 2009, the most recent data that we had California-specific numbers for, 12.2% of the economy was spent on healthcare, and in the U.S. it was 14.8%. So California costs are actually a little bit lower total than the rest of the country. But interestingly, that's not across the board for all payers. So that's overall, California is less than the US. But if you look at specific payers, and this is from a slightly different report you'll also find on our website, which is a survey of employer benefits. And these are average monthly premiums. And I know it's difficult to read. You've got copies of the slides in your packets. But the red bars are California and the gold bars are the US. And you can see the red bars almost always exceed the gold bars. So this is employer-sponsored health insurance. So even though California costs overall are lower, that isn't true for employer-sponsored coverage. It's actually more expensive in California than it is in other states, than it is in the US on average. So why are California costs so divergent for employers versus Medi-Cal and Medicare? Medicare, it's about equivalent to what's happening in the US. The big difference really is Medi-Cal. Medi-Cal in California pays significantly less than costs, and arguably it's the employer-sponsored health insurance that's making up that difference. So there are a couple questions I wanted you to keep in mind as you hear the rest of the speakers talk about how we pay for care is changing over time. So these questions are really fundamental. I don't want to specifically ask the speakers these, but to just keep them in mind, and you might want to orient your questions to the speakers that way. So what are the main drivers of healthcare costs, and how can payment reform initiatives address them? How does California's long-term experiment with capitated payment and integrated care influence payment models here? What are the best opportunities for lowering overall costs? And we'd like to see if they have any specific policy solutions to offer. So with that, let me turn this over to Suzanne and Andrea from the Catalyst for Payment Reform to talk a little bit about what they've seen overall.
Thank you, Mary Beth. It's a pleasure to be here. Oh, thank you. Before I get started, I wanted to just give some thanks to the many parties that made it possible for us to be here today to share with you the results of the California Scorecard on Payment Reform. First and foremost, the California Healthcare Foundation for the financial support and believing in this project, as well as the Commonwealth Fund, who was a co-funder. We also had a national advisory committee of a multi-stakeholder group of experts in payment reform, and also those who just frankly were representing different aspects of the industry of healthcare, help us come up with the domains that we wanted to capture in the scorecard and how to measure them. So I thank all of them. I also thank the Pacific Business Group on Health and 4 other business coalitions who were on the ground across the country trying to encourage health plans to participate in the project. And as we'll share with you, we gathered our data through an existing platform that gathers information from health plans on an annual basis called Evaluate. And that's housed at the National Business Coalition on Health that was a critical partner in the project. The data analysis was performed by NORC, so we thank them too. And then this is just giving you a sense of how complicated this project is that I have a long thank you list. I also wanted to thank Booz Allen, who helped with some of the initial work on the metrics, and Raven Creative, Group Visual IO, and last but not least by any means, Andréa Caballero, who led the work on the project, and my amazing team at CPR, who helped pull off what was quite a big feat. So let me give you a little bit background on who Catalyst for Payment Reform is and why we were interested in measuring where we are in terms of how we pay for care, both in the US and then specifically in California. CPR is a relatively new national independent nonprofit organization whose main purpose in life is to try to provide thought leadership to and coordination among some of the largest purchasers of healthcare in the country. So most of our members, if you can read the fine print here, are Fortune 500 company types, but we have a growing number of state agencies, including 4 Medicaid agencies and several employee agencies or retiree agencies at the state level. All of these purchasers come together because they believe that they can get better value for their healthcare dollar and that a really underutilized lever is payment reform. So when you want to create a movement and you want to create change, obviously one of the ways to do that is by getting those with leverage in the system to come together and have a consistent ask and set of demands and a set of goals that they're pushing for. And so that's much of what we do. But we also feel like to put wind in the sails of these purchasers, we need to have a sense of where we're starting from and where we're heading. And so we, in 2010, when we just were getting started, through a very large employer, put out a query to large national health plans and asked them what proportion of the payments they're making to doctors and hospitals are tied to performance. And at the time, it may not surprise you, although my favorite thing used to be to ask audiences like this to guess, what proportion of payment was tied to performance. At the time, it was somewhere between 1% and 3%. So we said to ourselves, okay, what's a goal that we can set that is some mix of ambitious and realistic? So we came up with a catchy phrase, 20% by 2020. We wanted to see a big change in how we were paying for care, and we'll get into some of the nuances of that in a moment. But having set that goal, it's very important then to measure where you are and to track progress over time. And so that's part of the other avenue of the work that we do, which is let's shine a light on what's broken about our payment system and then talk about potential solutions and track change over time. So that's where this project really fits in. It's actually a 2-part project. Today we're going to be focusing on the California scorecard on payment reform, but there's a companion piece that we're building called the National Compendium on Payment Reform, which is meant to be a resource to all of you, which is a searchable, sortable database of payment reform initiatives across the country. We only have 55 entries in it so far, and we're sort of embarking on a massive campaign to get health plans, provider groups, and anyone else who is sponsoring payment reform initiatives to share information about them. And it doesn't have to be the secret sauce, but we want to hear at a high level what people are trying and doing to help people connect with each other, to track change, et cetera. So that is a companion piece you can see on our website. But today we're going to talk about the scorecards, which really just present an aggregate view of how we're paying in the commercial market doctors and hospitals that are in network. It does not compare health plans individually by name. It was not meant to sort of highlight who's doing well and who's doing poorly. It's really just to give us a sense as a state of where we are. And the data are based on voluntary submissions by health plans. So it was really up to the health plans to submit the data, and that's part of why I thank them at the beginning here, because without their participation, we wouldn't have any information at all. So obviously when you come up with a title, the California Scorecard on Payment Reform, you have to decide what you mean by payment reform. And that's not a term that all of us necessarily at first glance or at first discussion would agree on in terms of what that means. So for the purposes of the scorecard, we worked with the National Advisory Committee to come up with a definition, which is that payment reform refers to a range of healthcare payment models that use payment to promote or leverage greater value for patients, purchasers, payers, and providers. What payment reform is not is all those other payment models that are independent of the quality of care or the value that the care provides. So that definition is very important in setting the parameters for our scorecard and the kinds of metrics that we have in it, as well as what's included in our compendium. Now you will hear us use a term that we kind of coined called value-oriented payment. We struggled with what is the phrase we want to use to describe what we think is reform as compared to what the status quo is. So to us, value-oriented payment means payment that reflects performance, especially the quality and safety of care that providers deliver, payment methods that are designed to spur efficiency and reduce unnecessary spending. But if a payment method only addresses costs or efficiency and doesn't touch on quality, we don't consider that to be value-oriented. So we want to see payment methods that both reflect performance and support quality improvement, and that's really where the focus of the scorecard is. So I mentioned we had a national advisory committee and that we partnered with the National Business Coalition and their Evaluate data collection platform. The overall results that we'll be presenting to you today are based on 7 health plans in California. It includes HMOs. The 7 health plans represent 20 million covered lives and 92% of the commercial market. So while we're missing little bits and pieces, it's a pretty comprehensive view of what's happening here in the state. So I want to just underscore again what the scorecard is and what it is not. It's based on voluntary submission of data. So the health plans who participated did it on a voluntary basis, and they didn't have to answer every question. For most of what we're presenting to you today, there are responses from all the health plans, but if they didn't want to answer the question, they didn't have to. And it really provides to you a descriptive summary of what's happening in California. It is not meant to be an academically rigorous study, but I still think, and I think you will agree, that the findings are incredibly illuminating in terms of what's happening here. So now I'm going to turn it over to Andréa Caballero, who did all the hard work to share with you what the results are.
Thank you, Suzanne. Thank you, Mary Beth. It's really great to be here to share the results with you. It may be a little difficult for you to see some things on the slide here. So this is the document in your packet. This is the California scorecard. So on the front cover here, you can see it on the slide. The first cover attempts to address 3 questions. And the first is, how much of commercial payments are actually value-oriented, as defined as Suzanne just described? The second is, what is the breakdown of those payments that are value-oriented? And then finally, what is the proportion of payments that are made to hospitals and physicians that are value-oriented? Those are the 3 categories of metrics that you'll see on this first page. In order to answer the first question, if you look in the upper right-hand corner, you'll see that in California, our survey of health plans showed that 42% of all of the payments in the commercial market paid today are considered to be value-oriented. The drops flowing down from the state of California, and that 42%, represent a wide array of payment reform methods. So when Suzanne talked about defining payment reform, we cast a very wide net. We didn't want to eliminate certain payment reform methods that are being used today by creating a narrow definition. So these drops represent different payment reform methods. And it shows what proportion of the payments are flowing to doctors and hospitals through these various methods. You'll see that there's shared savings, there's shared risk, there's fee-for-service plus pay-for-performance and other kinds of methods, including the large drop at the bottom, which is full capitation with quality, which probably doesn't surprise most people in the room here or on the phone. But we did determine through our survey that 32.5% of the 42% of value-oriented payment is in capitation here in California. You'll also notice that the drops of the payment reform methods are color-coded. We did this because we wanted to understand what is the financial incentive of the different payment reform methods. And the dark blue drops, again, the largest being capitation, reflects payment that actually puts providers at risk. That's a term that we use, and it's widely used, but basically it's a payment method that uses both a carrot and a stick approach. So there is an upside and a downside financial risk for the provider if you use one of these payment methods. And if you look at the blue drops here and then move to the center, you'll see that 97% of the 42% are payments that are considered at risk here in California. Again, capitation with quality really drives that at-risk component. The last metric on the first page relates to the penetration of value-oriented payments to hospitals and providers. We really wanted to know what was their experience on the ground with value-oriented payment. We hear a lot of stories about contracting and furious contracting and difficulty contracting. So we wanted to know what was their experience. And what we learned was that 30% of all of the payments made on the commercial side to hospitals is considered value-oriented. And then when you look at outpatient payments, again on the commercial side, which we include to be primary care physicians and specialists, approximately 52% of their payments that's going to them is considered to be value-oriented. So these are the headlines of the scorecard. And again, you're probably not totally surprised by the capitation number, but it definitely drives many of the additional results. So if you go to the inside of the scorecard now, we've identified 5 metrics, and when I say we, I'm referring to our advisory committee that helped us develop these metrics and identify them as indicators of payment reform that we can track over time. The first metric on this page is attributed members, and what we really wanted to determine was what is the experience of the patient with payment reform. Obviously, payment reform is a transaction that occurs between a payer and a provider, but what's the experience of the member? And it turns out that the most accurate and the best way to measure this was to focus on different delivery methods and models like accountable care organizations, patient-centered medical homes, and other delivery models where patients are actually attributed back to a provider. And in California, it turns out that 36% of health plan enrollment is attributed to physicians who have payment reform contracts and are engaged in delivery models like accountable care organizations, PCMHs, and other delivery models where the patients are then attributed back to a specific provider. The middle metric on the left-hand side really shows the spending between primary care and specialists. And there's a sense that we really pay a lot for specialty care, and we're not, I think we're moving towards it, but we were investing less in primary care. And we wanted to really test this out and see where we are as a baseline. Are we paying more for specialty care over primary care? And so of all of the money that we spend in California on primary care and specialty care, you can see that the vast majority of it, 72%, is paid to specialists, and the remainder is paid to primary care. So this is one as a benchmark that we want to watch over time, because as delivery and payment reform changes to emphasize primary care, we really should see those numbers change. The last metric on the left-hand side here relates to non-fee-for-service based payment that contains a quality component. And that's a little bit of a mouthful, non-fee-for-service payment, but you can think about that as capitation, anything that is not based on fee-for-service. And almost all of the money that's spent not in fee-for-service here in California includes a quality component. If you go to the right-hand side, we have a series of transparency metrics, and you might think one of these things doesn't quite fit with the rest of the metrics, and transparency is one of them in that it's not directly related to payment reform, although we really view transparency as a strong building block to payment reform. And we're in a process with engaging consumers, and we wanted to really track, are they receiving the tools they need in order to make informed decisions. And if you look at the first metric, you'll see that 7 out of 7 health plans, or 100% of the health plans that responded to our survey in California, said that they are offering cost calculator tools to consumers. But if you look at the last metric there, you'll see that almost 1% of consumers are actually using these tools. So we have this gap, and we can speculate on the reasons why there's this gap. It could be that it's difficulty to navigate, it's hard to find, but it also could be that benefit designs are actually shielding consumers from actually going out and searching for cost and quality information. So again, this is one we'll look over time to see as payment reform and also engaging consumers go together. The last metric in the scorecard tracks readmissions. And an early form of payment reform is actually non-payment, and it's non-payment for readmissions within 30 days. And the advisory committee decided to select this measure because it really is an indicator of both cost, efficiency, and quality. And it can be a correlate to payment reform, even though it's non-payment. So in California, our survey found that 8% of hospital admissions are readmissions. So when we track this over time, as hospitals are not being paid for these readmissions, we should see an improvement in quality, and it will track with the non-payment. And as Suzanne mentioned, the companion piece to the scorecard is the National Compendium. And at the top there is the URL. We certainly encourage all of you listening and in the room who are engaged in payment reform initiatives to go into the website and enter your programs. As Suzanne said, this is not intended to give away anyone's secret sauce or competitive information, but we want to be able to learn from each other and have this serve as a resource for journalists, academics, policymakers to really understand what is occurring where, and then from there eventually we'll find out what's working. So with that, I'll turn it back to Suzanne for some final remarks.
I think the results clearly give us important insights into payment reform that we didn't have before. It was amazing to me, that you would ask the leading health economists, how are we paying for care today? And people really had no clue about, the proportion of different methods and how they were being used. You hear so much talk about bundled payment, and it makes up the tiniest portion of what's happening right now, as just an example. So hopefully it will be helpful to many of us here in the room, on the phone, and others to know this information and to be able to move forward with it. It also, though, raises some really interesting questions, which is, it's one thing to know what methods we're using, it's another thing to know whether or not those quote-unquote value-oriented methods are actually producing better value. And that's really our next challenge as an organization, and many of our next challenges is to know, why is it that if we have so much value-oriented payment here in California, there's not a whole lot of evidence that we have much higher quality than the nation as a whole. And we may be better off a little bit economically in terms of the overall healthcare costs per person being a little bit less. But why is it that there's not a dramatic difference? So it may have to do, for example, in the capitation situation with the quality component not having a lot of teeth and not being strong enough. So there's still a lot to learn about how to make these payment methods work to produce the outcomes we hope they will and that they're intended to, which is higher quality and more affordable care. So that'll be an interesting discussion and debate to have. I also just want to use this moment to underscore again what Andréa said, which is that this is going to be an ongoing process. We're going to have a scorecard again next year for California, and so we just urge continuing participation in providing the information so that we can all work together to figure out where we are and move forward. And if anyone's curious about more of what CPR is up to on related notes, please feel free to visit our website. And if you want more detail behind the scorecard, what was the methodology, we have a set of frequently asked questions. You can find those on our website as well. So thank you so much for your interest and for the time.
So do we have any clarifying questions you'd like to ask either Suzanne or Andréa? Oh, great, we do have one. And then we'll keep most of the questions till after Joy finishes, but we could take a few now.
Hi, this is Cynthia Robinson, DHCS. Can you speak to differences between commercial product lines or state-sponsored programs? Is this all commercial product lines?
Yeah, so the data that you're seeing today is all commercial in-network information, captured by different product lines.
Any other clarification?
A minor question. Is the foundation going to make this available online in a little larger print?
Yes, absolutely. Okay. So what we'll have at the end of this session is we'll actually put the video of the entire session up, as well as all of the documents that we've referred to, including the scorecard, the slides, and then also referring back to the cost information that I shared at the beginning. So we'll have all that available on the foundation website. Great. All right, well, join me in thanking Suzanne and Andréa. And we'll turn it over to Joy to share a little more on-the-ground view of what's happening in different regional areas of California.
Good afternoon. I wanted to thank Mary Beth and the CHCF for inviting me to present today. And it's particularly fun because Sacramento is one of our study sites. So we really appreciate the opportunity to come back and share the findings with folks here. So I think the presentation by Suzanne and Andréa was really a great setup for my talk. I'm sorry, I have my slides up here. They really provided a good understanding of what we mean when we talk about the transition from volume-based fee-for-service payment to value-based payment. And so as Mary Beth suggested, what we're going to do is look under the hood a little bit at one particular type of payment reform that's getting a lot of buzz these days, and that is the Accountable Care Organization, or ACO. And the reason why people are interested in this is that the ACO attempts to address total spending across the continuum of care and give providers incentives to essentially keep patients healthy, not just focus on how to pay them when people are sick. So there's been a lot of activity in Medicare on ACOs, and that in turn has spurred a lot of interest on the commercial side in ACOs. So what exactly is a commercial ACO arrangement? As Suzanne said, all of these payment reforms are complicated and there's really no definitions out there. The most standard one people use to describe ACOs are that they are a group of providers, typically physician networks, sometimes hospitals and other providers, that agree to be responsible for the cost and quality of care of a defined population. And we'll talk a little bit more about what that means as we get into examples in California. But insurers essentially are contracting with ACOs, and in those contracts are terms that are intended to help reduce the total spending, total cost of care, and at the same time help maintain or improve quality. So really, if you've seen one ACO, you've seen one ACO. That's probably the bottom line from this study and anybody else who's looking at ACOs. But I think there are a few general statements you can make about ACOs. And I will say, starting out, that California, as usual, is unique, and we'll get to that. But outside of California, in Medicare and in the commercial ACOs, they're really being structured to help avoid the managed care backlash that we saw in the 1990s as health plans and providers were moving towards global risk or global capitation and essentially moving all the risk to providers. So what do they look like across the country? For the most part, there are new payment incentives that are incorporated into existing PPO and HMO products. They always have physicians in them. Sometimes they have hospitals or other providers, and it's often actually hard to tell from the publicly available information who is actually at the negotiating table as part of the ACO. Now, as I said, I think even with the ACOs, the idea is that eventually providers will move towards taking global risk. But at the moment, the way they're being structured is really to try to do this in an incremental fashion over time to avoid that quote-unquote backlash and what we saw last time in California and elsewhere in terms of providers having challenges managing risk. So there's a global budget for all spending across the continuum, and there's shared savings if providers are under budget. Sometimes, but not always, also providers have to take risk for the losses. And this global budget and the incentives around it are layered over existing fee-for-service payments. So the rates and the payments that existed before stay in place. Now, the idea behind this is, of course, to reduce unnecessary care, but to avoid incentives unintentionally to actually reduce appropriate care as well. Shared savings are contingent on meeting those quality standards, and Suzanne addressed why that's important earlier. So, and lastly, a thing that sort of a defining characteristic of these ACOs and Medicare and commercial ACOs outside of California is that it preserves patient choice of providers. So there are no incentives to drive providers, particularly to patients to ACO providers. So as I mentioned, California is in the vanguard of commercial ACO development, as well as many other things. And they were really one of the first out of the gate with the Blue Shield CalPERS ACO, which was launched in Sacramento in 2010. And since then, there's been a lot of ACOs that have been rolled out across the state. And one study estimated actually that 25% of commercial ACOs in the country were located in California. And we had a unique opportunity. Mary Beth explained that my organization, HSC, was conducting a study for CHCF looking at health system change in local healthcare markets in California. So we had a really unique opportunity, given the timing of the study, to look at ACO development in California. So I'm just going to briefly talk about the study design and then go over the findings, talk a little bit about what the factors are that are driving development, talk about what ACOs look like in California, talk about local market variation, and then talk very briefly about ACO benefits and challenges and the implications for the future. And we have a lot more detail in the study, which hopefully you'll have a chance to read. So as I said, this study that we did now, the results I'm presenting, was a follow-up to the original study, which was done in 2008 to 6 diverse California communities. And I'm just going to flip ahead to the next slide so you can see the sites that we studied in addition to Sacramento, and you can see there's geographic diversity as well as socioeconomic and other factors that vary across the markets. Oops, sorry. So this study that I'm going to present today are findings from about 200 interviews with healthcare leaders in those 6 communities that were conducted at the end of 2011 through the spring of 2012. And we had a heavy focus on the delivery system, and we in particular wanted to understand how providers, including the safety net, were preparing for health reform, including contracting with insurers. And we produced a number of reports, which Mary Beth mentioned, and they're listed in the back, and they're all available on the CHCF website. And I just wanted to acknowledge my co-authors on this paper, Ha Tu and Dory Cross. And as with Suzanne, it's really a full team effort. We had many more people involved in collecting all the data. So first of all, in order to understand what's going on in California, you have to understand some basic facts about the way the California market is organized, healthcare market is organized, and they really set the stage for the particular commercial ACO collaborations that we see, and they set them apart from the rest of the country. And the first is that there's a high proportion of commercial HMO enrollment with primary care physicians that act as gatekeepers. And as Suzanne and Andréa pointed out, there's a presence of large physician organizations that take capitation for physician services. And these include both medical groups and independent practice associations, which allow physicians and small practices to take risk. And that's unusual compared to the rest of the country. But one thing I wanted to say is that they do not take risk for hospital care. And hospitals are typically still paid fee-for-service or paid per diems. And this means that there are really fewer incentives to control hospital utilization. So what did we find? Well, I will say that just starting out, the ACO collaborations really mark a major shift in relationships between insurers and providers. In California, as in the rest of the country, historically, relationships have been really focused on price negotiation and have been at times adversarial. And that's what we found when we came in 2008. There was one thing that was slightly different, I guess, in California than the rest of the country at that time, which was that insurers were pushing back some on provider leverage by creating what we call limited network products. And I'm not going to go into a lot of detail here in the interest of time, but essentially they were noteworthy because these products often excluded prominent, high-priced providers. And an example of this is a narrow network HMO. The CalPERS was offered to CalPERS enrollees in Sacramento. So it was a Blue Shield HMO, and they excluded Sutter from the network at that time. And so these were examples and there were a couple of other examples across our other sites of these types of products. So there was interest in these, but it was unclear exactly whether there would be interest from purchasers and from enrollees in actually joining these markets when access was limited to certain providers. So, and now, excuse me, so clearly things have changed when we get here in 2008, and there are a number of factors that have helped drive those changes and push insurers and providers to sit down at the table together to try to come up and collaborate. So, and I'm just going to highlight the factors that are different than the rest of the country. And one of the things that makes ACO development unique in this market is Kaisers' growing dominance. So what that has meant for insurers and providers is that they have seen their market share decline as Kaisers' market share grows. This is on top of the fact that over time, HMO enrollment has declined because people have been moving into lower-priced PPOs, and because, as Mary Beth mentioned, because of the recession, there's been an overall decline in commercial enrollment. So basically, the pie is shrinking, and Kaiser's getting a bigger piece of it. So this has had a strong impact on insurers and providers. So insurers clearly are looking for ways to try to compete with Kaiser on price, and physician organizations also are seeing declining capitation, and they actually like capitation because they actually do better on it. They do better with capitation than fee-for-service payments under PPOs. And IPAs in particular can only take risk contracts because of antitrust regulations, and so this is really their whole business. So as it's been shrinking, they've been looking for ways to try to expand their business, to maintain or expand their business. And lastly, what we're seeing with the large hospital systems in California is similar to elsewhere, that they're really facing pressure for reduced bottom line from health reform, cuts in Medicare, as well as the move to value-based payment. And so they were looking for opportunities to try to, essentially, they're seeing ACOs as really an opportunity to experiment with how to manage the total cost of care at a time when they still are getting paid predominantly fee-for-service and doing well, and able to bear the expenses involved in investing in these types of programs. So, so what we found in California is that the early ACOs were limited network products, and they were really being designed as lower premium products to compete with Kaiser. And as I mentioned earlier, this is really different than the rest of the country, where the ACO products are typically just new payment incentives layered over existing products. In this case, they're actually new products. And what they have, the key component is, as I mentioned earlier, in the rest of the country, there's really no effort to steer patients toward ACO providers. In California, that's the major component of this design. The idea is to steer patients towards ACO providers. In an HMO ACO, the only providers in the network are the ACO providers, and in a PPO ACO, the idea would be that there would be lower cost sharing for ACO providers, but there's still opportunity to access non-ACO providers. So I just wanted to show you here that we found commercial ACO products in 4 of our 6 sites at the time of the site visit. The 2 sites, Riverside, San Bernardino, and Fresno, there was no commercial ACO activity at the time. And you can look in more detail in the report if you're interested. So I wanted to talk about a couple other key features from the ACO products. As I mentioned, it was really the IPAs that are particularly interested in the ACOs as a way to try to maintain or expand their market share. So they were really the leaders on the provider side in the ACOs that we saw. The hospitals were participating in the HMO ACOs, but not in the PPO ACOs. And in fact, these ACO arrangements really do start to align the financial incentives among all the parties that are participating. And I think, in the 1990s, global capitation was really give the money to the providers, and they'll have to figure out how to manage it. These relationships are changing, and the idea is that the insurers and the providers are at the table together trying to figure out, who best can help manage care. So there are some differences in the features between the HMO and PPO ACOs, and there's a lot more detail in the paper. I'm just going to talk briefly about the Blue Shield CalPERS HMO in Sacramento. And this was a case where the hospitals were participating along with the insurer and the IPA, and they developed a three-way shared savings and loss program. And they, as I mentioned earlier, they really took opportunity to figure out who was responsible for each of these buckets of services and who should bear the costs as well as the benefits from setting up the global budget. Excuse me, I'm sorry. And I'll also just point out that CalPERS actually got a zero premium increase for the first year that this was rolled out, so they had a greater incentive, all the parties had a greater incentive to try to, in fact, produce the savings. So on the PPO side, I just want to talk a little bit about the Anthem PPO ACO in San Diego. In this case, the physician organizations that were involved received a care management fee on top of their fee-for-service payment, and they had share savings only, no losses. They didn't take risk for losses, I'm sorry. So, and there are really challenges to managing care compared to an HMO ACO because patients are able to see non-ACO providers. And in this case, the hospitals were not participating initially in the ACO. So, overall, hospitals face greater disincentives to join ACOs because essentially the lowest hanging fruit for these ACOs, the way to cut payment, is to cut hospital volume, both admissions and length of stay. So hospitals face this reduction in volume. On the other hand, they have potential to increase volume if they gain market share from these limited network products and potential to get some of the savings back. So, and the PPO product, again, adds more complexity because it means that patients can go out of network. So it's a very complicated a calculus, particularly for hospitals, in deciding whether to join or not. So briefly, just in terms of local variation in ACO development, we saw a lot of variation across the state because those market conditions that I talked about earlier really vary by market. Sacramento and San Diego had the most activity. San Francisco and Los Angeles were a little farther behind, and as I mentioned, Riverside, San Bernardino, and Fresno really didn't have much going on at all at the time of the site visits. So briefly, I just want to say, you need strong Kaiser presence, as we noted, and large physician organizations interested in more risk sharing. And a key thing that's necessary in setting up these limited network ACOs is that you need price competitive hospital systems and POs that have a big enough geographic breadth and scope to be able to support a limited network product. And you also need sufficient competition. If you're a dominant hospital dominant hospital, why would you set up an ACO if you're not competing? So, and we saw sort of variation in terms of purchaser activity. And again, there's a lot more detail in the paper to cover. So in terms of ACO benefits and challenges, clearly there are incentives for this sort of virtual integration to help insurers and providers operate similar to Kaiser, but no magic bullet for slowing spending. Really, they're investing and investigating all of the same kinds of strategies providers elsewhere are doing in terms of trying to control costs. And even in California, they found that they had substantial infrastructure investments in things like IT and process change to be able to meet their target and actually get savings. So, and in particular, data exchange was very challenging, both in terms of IT, but also in terms of kind of negotiating the terms of sharing sensitive performance data. I think as the early findings showed that having hospitals involved is really important because physicians can go only so far in being able to control the cost of care in the hospital setting. And there are really questions, though, even with early the early results coming in showing that there were savings from implementing the ACOs, that a lot of these savings again come from cutting hospitalization. And once you do that, the question is what's next, and can you sort of maintain the same rate of savings that you've had at the beginning, and this really gets into how you have to try to structure these ACOs over time to provide appropriate incentives. So just briefly, in terms of the implications for future ACO development in California, clearly the jury is still out. These are new. As I said, there are concerns about the extent to which cost savings they can continue to find cost savings over time. And as the people involved in them have noted, it takes a long time once you kind of squeeze out the inefficiencies and the low-hanging fruit. It takes a long time to yield results. And the other thing is, and I think I was a little remiss in how I covered this earlier, but part of the incentive for providers in participating in these ACOs is to gain market share. And we don't know yet whether, how well these products are going to sell. They've kind of had the initial enrollment from for example, in the CalPERS, it was the existing enrollees at first, and then they opened it up to anybody who wanted to enter into this product. So I think the jury's still out about this, and I'm short on time, so I'm just going to say a couple more words. First, in terms of California, there's still more to be done in terms of clinical integration across the care continuum, and refining payment mechanisms are really just at the initial stages of figuring out how this all works. And it's a long way to go to get to global capitation. And we can talk about this issue of regulation if there are people in the audience who want to talk about what this means in terms of providers bearing global risk. Oops. I'm sorry. So, and then just sort of thinking very briefly about outside of California, there's clearly greater potential because they're starting a little behind folks in California, as is often the case. But it's unclear whether these kind of limited network products would really be attractive in other markets where patients are not used to gatekeeping at all. And it's really a longer time horizon to get the infrastructure in place among providers to do it. And it's unclear whether hospital acquisition of physician practices are really going to help with clinical integration or not. So I think basically we're at a point where it's really exciting, we're seeing lots of things happening, but we don't know where it's going to end up. And so thanks to CHCF and other folks, hopefully we'll be able to continue to monitor what's going on, because I think there are going to be both micro lessons in terms of all the different ways providers are trying to control costs while improving quality. There's those micro lessons that can be applied in different ways across the healthcare system, as well as the more macro questions about payment reform. Thank you.
Great. Thanks very much. Yeah, that's okay. So thank you very much, Joy. So we can take a couple of questions. Anybody has a question? All right. Great. Thank you.
Thank you. Thank you. You talked at the beginning about the moderation and the increase in healthcare costs.
Yes.
Most of the studies I've looked at attribute at least some of that to more consumer cost sharing introduced by large employers for their employees. Does that, what implications does that have for trying to promote value-based payment? It would seem it would make it a little more complicated.
Yeah, so do you want to take that, Suzanne?
Sure. So, the way that we think about it is that it's probably pretty important to align the incentives all along the continuum. We can't expect all of healthcare to be solved by putting more onus on consumers, and we can't expect all of healthcare problems to be solved by putting the onus only on providers and not engaging consumers in the process. So our view is that both pieces are important, and that we're missing some really fundamental building blocks to do that. You can't really expect consumers to be smart shoppers if you're not giving them the information they need to make good decisions. And you can't really expect providers to change their behavior if there's a cacophony of different payment methods being thrown into the mix with all different incentives. So the alignment is just incredibly important here, alignment across that continuum of all the stakeholders involved, but also across sectors. And Mary Beth referred to how the payment levels are so different from Medi-Cal to commercial. There's not just the levels, but there's also the methods. So there's a lot of sort of aligning and streamlining to do, I think, to make all of these incentives more potent and working in concert with each other.
Deborah Kelch, independent consultant. I think this is a question for Joy. I'm just curious to know if in your study you were able to better for all of us characterize this notion that is quite the buzz of the new and more limited network. So some of that's obvious when you, for example, in the Blue Shield case where they excluded a high-profile hospital system. But as we all hear and learn that we are living with narrower networks, were you at all able to give us more of a peek at what that really means in terms of more narrower than what we had before, than what we think is right? I mean,
Right. Well, I think the ACOs that I presented here are much more limited because they're really focused on a specific group of providers, the ACO providers, which were often, for example, in the CalPERS ACO in Sacramento, it was Dignity Health and Hill physicians. And they have some wraparound providers, to fill out the geography if they need to. So those are much more limited products, and so people go into it knowing, here's what my network is, and I get a lower premium, I get reduced cost sharing, so they make the choice up front. In the tiered network products, they have more control over where they go, so you can say, well, in general, I'm going to go to this, the ACO provider, but if I get sick and I want to go to a different provider, a well-known cancer center, for example, or something like that, you can do that, but you pay more for it. So I think that's different than, I think, some of what's going on in terms of the exchange products, where it's more of this unilateral approach where the health insurers are, lopping off parts of the network where they think providers are high-priced providers, or alternatively, they're saying you can be in this network if you accept a certain fee schedule. So it's a little different, and I think they're still evolving. So I think, I just saw an announcement that Anthem is rolling out another ACO product, and they did mention that some patients or some enrollees would have access to that ACO product under an exchange, some of the exchange products. It was a little unclear what that means exactly. So there may be some meshing of these two things, but they're a somewhat different design.
Right. Yeah, it'll be very interesting to see how some of the narrow network products that will be offered as part of Covered California on Tuesday, what kind of populations they'll attract and whether or not those networks are going to be adequate to serve the number of enrollees. So I think there's going to be a little back and forth as health plans try and right size based on who ends up signing up. So it'll be interesting to watch over the next year or so. Another question?
Thank you. Good afternoon. Ann McLeod, Senior Vice President, Health Policy for California Hospital Association. Appreciate the foundation putting the program on today. We do believe that payment reform really is an important element of the overall picture of healthcare reform. And what I have today is really not a question, but maybe a couple of comments and some information you can take back as you work with your good work going forward. We do believe there does need to be a movement from providing care to managing health. It won't be easy for all providers or groups of providers to make this happen. However, especially as you consider in a highly regulated industry, this shift can be difficult because of legal barriers that limit how providers can work together, something that needs to be considered. Also, the issue of cost must not be lost. Drivers of cost, which were touched on today, some of them, but not all of them, and I think they really need to be emphasized. The number of uninsured served by a certain provider in a certain community, the cost shifting of government losses. For example, the Medicare program in California underfunds hospitals $3.6 billion a year, and the Medi-Cal program provides less than what the cost is of providing care by over $5.2 billion a year just to hospitals. There's also the cost of graduate medical education and training for the healthcare workforce for tomorrow. There's also the cost of research and clinical advancements. For example, a community hospital that provides care in its community also has a research and teaching mission. One in California specifically was instrumental in developing minimally invasive surgeries that really benefit the entire system. These are examples of healthcare providers that bear a greater burden that are reflected in their cost structure. And we must determine how society values those benefits and who will pay for them. Until we do, we run the risk of well-intended payment policies, especially those carving out and creating these limited networks, really having unintended consequences. Thank you.
Great, thank you. Yes, we have a question in the back.
Hi, this is Judy Sitko. I had a
Hi.
question. There's lots of talk up here about doctors and hospitals, and when I think about the portion of patients who need long-term ongoing care, you know, they're going to need care not just in doctors' hospitals and in doctors' offices and hospitals, but through skilled nursing, home health, hospice. So how does this discussion today relate to them, or is it totally irrelevant?
When Medicare launched this ACO idea and asked for proposals, I think there was a vision that there broad networks would be proposed, and that isn't really what's materialized in some of even those Medicare ACOs where they are serving patients likely with long-term care needs. So I think there's been some outreach into those provider types, but probably not sufficient. And I think we probably haven't seen much at all in the commercial ACOs.
Right, and I think that's true, and in part because it's a much lower part of the spending on the commercial side. However, I think in the Medicare program, it's key. I don't think, you know, there are a smaller number of Medicare ACOs that have, I mean, there are a few that do have post-acute care and other providers in the ACO itself, but I think that the hospitals and the physicians involved in these ACOs are recognizing that this is important because of the spending trends in post-acute care. And I think I was just actually at a panel this week talking about the pioneer ACOs, and one of the people who was presenting as a hospital system, and they brought that up as one of the key challenges in managing spending under the ACO, is that they needed to pay more attention to post-acute care, and it means changing relationships with post-acute care providers in the market, because in many markets it's been sort of an arm's length relationship over the last number of years. And so I think that, and also the Medicare readmissions efforts are also pushing providers to realize that they need to start paying attention to them more.
Great, thank you.
Hi, Calla Haley, Center for Connected Health Policy. Now, my question may be completely outside of the scope of your research, but I was wondering if you saw any evidence of some of these organizations looking to optimize their use of telehealth to address payment reform.
So that's a good question. We didn't really get into that, I think, because you know, that is in that bucket of things I said that, you know, everybody's trying to figure out how to use. So that in particular did not come up. I think the issue around health IT more generally certainly was relevant, and that a lot of those investments came from both, you know, not so much necessarily clinical management, but management of data that that the physician organizations, even though they're already managing risk and have all these patients, needed to actually invest more in being able to identify high-risk patients, and needed to do more to figure out how to exchange data at discharge and things like that. So, and then there's sort of the data analytics that the insurers, the health plans, the insurers, the providers, and the physician organizations and the hospitals need to be able to get together and make their IT systems work to exchange clinical data as well as administrative data in real time, and that's a huge challenge. So I think, California, in some ways there's a lot of infrastructure there, but they have the same challenges that, people do everywhere in terms of trying to move forward with health IT.
Yeah, I just want to add a comment on that, which is that we didn't address that at all. And to the question that was asked earlier about the scope, just due to the resources we had and the database that we could tap into, it's focused solely on hospitals and doctors. And I think for the commercial market, it is the most relevant piece to focus on. But to your point, I think there is a lot of activity beginning to happen that's been going on in these other care settings that is really important to look at as integrated into the big picture. And to the telehealth question, it's absolutely something that large employers are looking at as they face markets that are really tough in terms of finding good value. They're trying to find ways not just for employee satisfaction, but also for better utilization of higher cost services like emergency rooms, to use telehealth, especially on the sort of primary care mode, as a way to control their healthcare spending and improve the quality of care.
Thank you.
Hi, I'm Lisa Gottby with the City and County of San Francisco, and we have 2 of the ACOs that you mentioned that we've had in place for about 2 years, and I just wanted to, say that I agree with everything that you said in terms of the challenges with the ACOs and the opportunities that they're presenting. I think we saw basically a 0 trend the first year, and then a negative 3% trend in our overall rates the second year, and we're continuing to see just really remarkable changes in the way healthcare is being delivered, especially around those most complex and catastrophic cases, how those are being really well managed, and to talk about the need for acute and long-term rehab in those ACOs is an important part of that, as well as palliative care planning and the whole gamut. I would say that as long as as an employer, as long as the value of those ACOs continue to be there for us, we're going to continue to invest and make sure they're successful. The issue of hospitals is a challenge, keeping them motivated when the whole goal is to decrease utilization in the hospitals. So how to keep them engaged is an ongoing challenge that we're working on, but I just wanted to say that I think they're here to stay for a while, and it's going to be interesting to watch them evolve over time. I did have a question for Andréa. Great to see finally our California numbers. Has a Catalyst for Payment Reform or the advisory or the partners you're working with, have you identified regulatory barriers that we should be focusing on in terms of furthering payment reform in the state of California?
As Suzanne mentioned, our advisory committee was multi-stakeholder and it was national in scope, so we did actually have quite a conversation about regulatory barriers to payment reform, whether it's the structure of how payment flows either between providers or others, but we didn't identify specific barriers here in California or nationally.
Which brings up an interesting question about policy solutions in general. Are there things that your employer groups, for example, would like to see change that would kind of facilitate this development, or anything, Joy, that you saw in the local markets where, anything from a policy standpoint that ends up fostering development of these innovative payment arrangements?
I think it was appropriate that at first when we were opening the session that we said it was on price transparency, because I think that is a very related topic to payment reform. And so when it comes to changing or things that policymakers could do to facilitate a higher value healthcare system in the future, we think transparency is absolutely key. And we've made a lot of progress. 10 years ago, we were still at the infancy of quality measures being available, but the ones that are available today are really meaningless to consumers for the most part and don't show differentiation among providers, because it's the safe and easy thing to do, but it's not really that helpful. And we're slowly but surely having more price information available, and we've done a lot of work on price transparency both in the public sector and private sector to try to get all the wheels in motion to support consumers in the way that they need. But ultimately, how can you assess whether you're getting good value for your dollar and whether your spending methods are working well? You need information. And so I think there's a lot that policymakers can do to absolutely ensure that it's available. I'm speaking next Wednesday in Massachusetts at their 4th annual cost hearing, where they subpoena people and they get the information they need to see how the state is doing. And not to say that that is necessarily the right model for every state, but the point is that policymakers can play a role in making sure that people can make informed decisions about how to make sure that healthcare is high quality and affordable. And so I think there is definitely more of a role.
Sure. I wanted to address one policy issue, and I'm not sure if this is helping facilitate it or not, depending on your view, I guess, and that has to do with regulation of ACOs and risk-bearing provider organizations. And I think, as you mentioned, I think it's, going to be a long process as these things evolve, assuming that, the market conditions stay right for them. And I think the question is really, how do you make these work and work well for everybody? So I think that, the Department of Managed Healthcare and other folks are engaged in thinking about, what kind of regulation is needed or not needed to help support it. But you want to think about putting appropriate safeguards in place so that as these products are designed and move forward, they work well. So that's one issue, I guess. And the other issue, I was thinking about the safety net. We didn't really talk about safety net and the extent to which the ACOs or some version of them are viable for the safety net and the Medi-Cal market, and there is activity underway, as I understand it. I know less about that. My colleagues, Lori Felland and Dory Cross, wrote a paper about the preparation of the safety net for health reform. And
ready or not.
Yeah, there you go. Thank you. But I think the question is whether if there are really opportunities, particularly when you think about the exchanges and the population of people coming onto the exchanges, that there's a whole group of people who have very specific needs, and thinking about how to develop those programs on that side. I think if there's potential there, that they'd be able to take advantage of that as well.
Great. Well, thank you very much for participating. We do have another session in 3 or 4 weeks, 4 weeks, I think, that is the second half of this, which really does focus a little bit more in depth on price transparency. So you'll see a notice coming out in the next week or so inviting you to that as well. So thanks very much. Karen reminds me, evaluations, we really do appreciate your feedback so we can make these sessions better and more relevant for you. So if you could fill those out, that would be great. Thanks very much.